Okay, try now.
Hello.
Hello, Jenny. Sorry.
Hi.
Yes. Sorry, we're just having some technical issues, so we're just trying to solve it. We should be up and
Okay.
running in 5 minutes.
Okay.
And we're going to keep the questions for the end, and so we can ask the question times will be for 15 minutes in the end of the session. Thank you very much.
Thank you, Dr. Jaleel Muhammad, for a beautiful introduction. I submit the delighted greetings from the Yenapoya Deemed to be University, which is in the southern part of India, Bangalore. I welcome you all. I'm getting the sorry, there is some technical error. Yes. I welcome you all for the session. My topic is early identification of scoliosis in children and focused early intervention and improved health-related. My first slide where we have to make a friendship with a scoliosis. So we are making friendship only with one type of scoliosis, that is called as idiopathic scoliosis. Coming to the presentation of keywords, what keywords we are going to discuss in this presentation is we are going to deal only with the idiopathic scoliosis, not all the types of scoliosis, and we will see what is the prevalence rate of, what are the cosmetic concerns, what is the impact of screening, and what is SOSAT approach. So these are the keywords of my today's presentation. Coming to idiopathic scoliosis, when we talk about idiopathic scoliosis, we all know that it's an idiopathic etiology, which has been defined by Whitman in 1922. And Cobb put the term in his classification promoted by the Scoliosis Research Society, said that idiopathic scoliosis is the lateral curvature of the spine more than 10 degrees in the coronal plane. Came in 2007, he said, Pigot et al., he reported that onset of idiopathic scoliosis is the result of faulty muscular and the actual changes in the muscle, which are due to structural changes that predispose the muscle pathology. So we can say that Pigot has reported that it is not only the bony deformation, it can be due to the faulty musculature and which predispose the muscle pathology. Another scientist in 2013, Benson et al. Said idiopathic scoliosis are affecting 2 to 4% of adolescents. So it has been proven that 2 to 4% adolescents have been affected by idiopathic scoliosis worldwide. When we come to the classification of idiopathic scoliosis, the classifications are given by King et al. And Lenke et al. King et al. In 1983 introduced the classification of idiopathic scoliosis in 5 patterns based on the location and severity of the coronal deformity, whereas Lenke et al. In 2001 introduced 42 potential patterns, and he said that it may be depending upon the curve type in the coronal plane, the alignment in the sagittal plane, as well as the rigidity of the curves on lateral bending radiographs. Lenke et al. Also said that greater than 25 degrees on the bending radiographs are called as structural curves, whereas equal to or less than 25 degrees are called as non-structural scoliosis. The most prevalent curve types are primary curves, and they are right-sided curves called as thoracic curves. These are the two classifications given by the two scientists about the idiopathic scoliosis. another scientist, he said that pediatric spinal deformities may develop and progress around the pubertal growth spurt. When we see the pubertal growth spurt, or when we go for the pediatric spinal deformities, we see most of the deformities in the pediatric conditions we can see is the kyphosis, scoliosis. These are the most common pediatric deformities. But Dixon et al. In 1988 and Borenson in 1886 said that pediatric spinal deformities normally develop and progress around the pubertal growth spurt. When the child is at the level of the puberty, when the growth spurt and the spinal growth is getting developed, during that period, the spinal deformities are more formed in the pediatrics. And the same scientist said that the girls are far more often affected by the idiopathic scoliosis, whereas boys are more affected by the Schauermann's kyphosis. So it is already proven that the prevalence rate of idiopathic scoliosis is more in girls and Schauermann's kyphosis is more in boys. There was another scientist called as Scholar et al. In 2015. He concluded that nearly inclined and stage development as well as compared to the girls after the growth spurt. So we can say that he has said that that spine of a girl during puberty, during the growth spurt, is posteriorly inclined and it is thus rotationally less stable than the boys. So these may explain the incision and progression of idiopathic scoliosis are more prevalent in girls around the puberty. Malco et al. In 2006 said that there are two rapid skeletal growth periods among children, whether it's a boy or whether it's a girl. So the birth to 5 years is one set of period and onset of puberty is the second set of skeletal growth period. So Dimalco said that this period can pose some risks to the quality of posture occurring during the puberty stage. So these are some evidences what I have just put into my slide, saying that pubertal growth spurt is the correct, or it can be the age where the idiopathic scoliosis can be detected. So when we coming to the prevalence age, there was a scientist called as Saika et al. In 2002. He said that 0.2% of the populations with girls have a prediction over the scoliosis, and the ratio he has given as 2:2:1. So he says that there was more prediction rate among girls than the boys. Another one, Konexi et al. In 2013 conducted a study on prevalence of scoliosis, and it was a screening-based study where the school children were screened, and he also detected that the prevalence rate was more among the girls than the boys, and he has given a ratio of 3:1. These are some studies. If you see the slide over here, these are some studies conducted in some Asian countries where they have done a school-based screening for 10 to 13 year or 10 to 19 year of the children. So approximate age what we have put over here is from the 5th grade. That is 5th grade in Indian standard. It is around a 10-year-old child or a 9-year-old child. From the 9 to 19-year-old children, these studies have been conducted in several Asian parts of the country. That is below 10 degree and 20 to 30 degree of the Cobb angle was detected among those children. But again, if you see the prevalence rate, it was more in females than in the males. So this reveals, or this gives us a scientific evidence that idiopathic scoliosis is more prevalent and more common among the girls than the boys at this particular age, that is 10 to 19 years. And et al. In 2014 said postulates as a factor in scoliosis. He said it has got a profound factor and profound effect on bone metabolism and the pubertal growth. And he has found that bone quality dearrangement has been seen in the idiopathic scoliosis girls. Sorry, one. I could see some, yeah. So Sinan et al. Said that in 2019, he said that leptin level differences between males and females are significantly affecting puberty. So with the dimorphism, females have females have more than 40%. They have 40%. I think someone is talking in between and I have to mute them all. Sorry for that. Yeah. Sinan et al. Said that leptin level differences between males and females are significantly affecting during puberty. With the dimorphism, females have 40% more leptin, which correlates with increased fat accumulation and adipose volume. So this study reveals that during the puberty, when the child goes for the puberty, we have a leptin level, and that is more, 40% is more among females than males, and it has got a correlation between the fat accumulation and the adipose tissue. And there have been many studies conducted where they have seen the biomechanical considerations, they have seen the epidemiological considerations of the idiopathic scoliosis, and the genetic considerations were also taken in the idiopathic scoliosis. And in that, they have seen that certain criteria, one group, one categorical group was there where the leptin level was more in the females. That was the genetic variations, which I'll be showing in the next slide. So that is also one cause for the genetics. And the fat accumulation around the girls, when there is a more fat during the pubertal age, that is also one predisposing factor for the idiopathic scoliosis. And along with its effects on idiopathic, that is adipose synthesis and metabolic effects, leptin plays a very crucial role in the bone formation and growth through the activation of the sympathetic nervous system or the sympathetic system for the skeletal growth. Idiopathic scoliosis have been strongly linked to increased leptin level, which can understood as dysregulation of symmetrical spinal growth, further explain the increased idiopathic scoliosis rate in the females. So in this slide, we can just come to the conclusion saying that the leptin plays a very important role in idiopathic scoliosis. And when we go to the some sort of leptin regulation, and we have seen that in females, it is 40% more than in the male. And same scientist in 2019 said that this leptin resistance resulting in leptin hypersensitivity can incorrectly activate growth signals in the body, resulting in disruptions of the osseous and neural escalators, which can exaggerate or exacerbate non-pathological asymmetries in females. So this is not pathological symmetry what we are seeing in the females. It is all the non-pathological asymmetries in the females due to many predisposing factors, which can be post-genetic variations, which can be due to the irregulation of the leptin in pubertal. Prepubertal growth spurt girls are at the age of 10 to 13 years. So when the child, especially when we talk about a girl at the age of 10 to 13 years, the prepubertal growth spurts are at this level, where the skeletal is getting matured at the level of, in the age group of 10 to 13 years, where the riser sign is 0 at standard and the progression factor is 2. And the idiopathic scoliosis have the chances to go for the progression of around 90%. So this age is more prone to get the idiopathic scoliosis, and it has got more prone factor to go for a progression of around 90%. Premenarche girls in descent phase says that Bess et al. He said that that is the descendant phase and it has got a better prognosis, and if the curve is less than 30 degree, it is very improbable to progress after growth cessation has taken place. So that is the best period. Prepubertal period is the best period when a child can be conservatively treated for the idiopathic scoliosis, when the skeletal maturity has not has not stopped. So when the skeletal maturity stops, so then conservative management is very difficult for idiopathic scoliosis. And another scientist, Lonston et al. In 1984 said that Prepubertal period is the best period and the perfect period for training, and it has got higher gain in density of bone. As I already mentioned in the previous slide, saying that idiopathic scoliosis have got that bone metabolism and the bone deformation, and they have got the less BMI. So many studies have proven that the idiopathic scoliotic girls have the less BMI, and but during this prepubertal age, when we are giving the correct and conservative management at this proper age, so there is a higher gain in the density of the bone. Now, coming to the regional variations, genetic differences, there is a scientist called as Kyung Due et al. In 2016, he has done a study on different population for different countries, where he found that there is a genetic differences. The study was conducted actually in Malaysia, where he took the participants from different origins and from different genetics. Like some participants were from India, some were from China and Chinese population, Indian population and Malaysian population, where he found that there was idiopathic scoliosis among all the girls, but he found the genetic variations. There were the genetic variations, and he found that the idiopathic scoliotic girls were more among the Chinese population. So there are certain genetic variations also. And if we conduct a study also in India, we have different parts of the India. One of the study was conducting in 1984. It was conducting way back in somewhere in West Bengal. They found that idiopathic scoliosis was more prominent and it was more prevalent among girls, but there were also certain age differences, and there were also certain genetic differences and the regional differences. So likewise, if we just go for another study, suppose we are taking in the northern part, the genes and the genetics vary. So in short, I would just like to convey the message saying that there are genetic differences, there are regional differences in idiopathic scoliosis. Now coming to the next slide. Ishida et al. In 2015 said that the serum levels of tartrate resistant acid phosphate serum band, that is 5-TRAP5B, was correlated between bone metabolism and bone density. It was found that the density in idiopathic scoliosis patients showed higher rates of bone reabsorption. So in this study, the Ishida et al. Have proven that there is a correlation between the bone metabolism and the bone density. When we talk about the leptin has got correlation with the bone metabolism and the bone density. And again, this study reveals that when there is a less bone metabolism or there is a less bone density, those patients or those girls or those boys are more prone to get the idiopathic scoliosis. Whereas this study was again conducted among the boys and the girls, and this study also showed the high prevalence rate among girls, and he has shown that the idiopathic scoliosis among girls, and they had higher rates of bone reabsorption but lower bone density. When we talk about the other study conducted by Sun et al. In 2013, he said that bone mineral density has been proposed as a prognostic factor for curve progression in patients in idiopathic scoliosis. Premenarchal girls with lower BMD, that is bone metabolism density values, were seen to have greater curve magnitudes at lower riser signs and the main thoracic pattern. So here again, at this age group, the curve was at the thoracic pattern. The curve was found at the thoracic level, but they had a greater curve magnitudes, and they have found that there was a prognostic factor and there was a bone mineral density which was low again in these patients. So again, we can come to the conclusion saying that there is a correlation between the bone mineral density and the idiopathic scoliosis. Separandio et al. In 2014 said that white adipose tissue strengthening the triglycerides and role of leptin postulates the disharmony between somatic and autonomic nervous systems in the spine and trunk, and are exaggerated by hormonal dysregulation resulting in skeletal overgrowth. Ultimately, it can risk in physiological trunk, with width deviation or biomechanical disturbances in skeletal framework. So when we talk about the white adipose tissue, so during prepubertal age, when the girl has got many hormonal changes, there are the dysregulation of the hormones, the adipose tissue, which has got the correlation with the leptin, has a disharmony between the somatic and the autonomic nervous system, which results in the skeletal overgrowth, and which can result due to any sort of factor, which can be poor posture, which can be genetic differences, which can be genetic variations, that can result in the physiological trunk width deviation, or it can result to the biomechanical disturbances in the skeletal framework. Now, coming to the another study, Ishida et al. Again, he has said in 2015 that it has got a lower bone density was found in the idiopathic scoliosis girls, and another study was conducted by Goldberg et al. In 2002. He said that there were three scientists, actually it was a combined study conducted by all of them, and all these studies have shown that high physical activity has a direct relationship with high peak bone masses. So in this studies, all three scientists like Goldberg, Asher, and Havas, they have done the study in 2002, 2006, and they found that they have given the high physical training to the idiopathic scoliosis patients, those who had a lower BMD, and they found that there was a direct relationship when they were given a physical training, and after post-training, they found that there was a good correlation between the BMD, that is pre and post. That is another scientist called as Lonston, Carlson, and West et al. They said that prepubertal period is the perfect period for training, as higher gain than loss in the density of bone occurs in this period. This was about the idiopathic scoliosis. What is idiopathic scoliosis? Then what was the classification, and what are the etiological factors? What can be the factors? When we talk about the prevalence rate is more among girls, but we have to give the justification why it is. So I have given you the justification, certain justification why it is, because leptin is the main component which plays a very vital role in case of females when they are hormonal dysregulations are going on, and that plays a very important role in the skeletal deformities. That is the one cause which can be the cause for the idiopathic scoliosis, and others can be the genetic variations or poor posture, etc. So now coming to the psychological and cosmetic concern. When we talk about idiopathic scoliosis, so we think, yes, idiopathic scoliosis, a girl or a boy or any child, we just talk about, now I'm just targeting on the girl, so I'll be just mentioning a girl, because when they get an idiopathic scoliosis and the child gets depressed. So there has been many studies conducted on this psychological and cosmetic aspects. So scoliosis not only affects the child's physical appearance, it may lead to pain symptoms and feeling of isolation, social isolation, and has an effect on the child's self-esteem. So another study was conducted by Winston et al. In 1999. He said that psychosocial impact does not seem to be manifested in adolescent patients unless the magnitude of the lateral curvature is severe, but the presence of rib hump and the shoulder imbalance. However, the simple act of buying clothes to mask the deformity in patients with minor curves can have major psychological implications in some, where others with more severe deformities may be more accepting of this condition. I would like to share my personal experience with this. And as my PhD topic is on idiopathic scoliosis, I was going through different schools to collect the data to screen the children. When I come across few children, few girls, they were so depressed because they were not knowing what exactly is happening with them. So when we were screening, we got the permission from the higher authorities to screen the children. When we screened the child was very depressed. When I asked them, when you put on your t-shirt, so when you look at the mirror, do you feel any difference? Many of them raised their hand and they said, yes, ma'am, we feel that our one side of the t-shirt drops down, and we like to go out with our friends, we feel that our one side of the t-shirt is flipping down. That really makes us depressed. So this is not that. Psychological concern is not only for the larger magnitude of the curve, it can be for the minor curves as well, where parents, teachers are not aware of this curve. So that is the main motive, what exactly we have to do in order to make the awareness about the scoliosis, and in order to get the patients rid of the psychological and the cosmetic concern to improve their health related quality of life. Another scientist called as Fedel et al. In 2002, he concentrated on health related quality of life in scoliotic female patients and found that adolescents were unhappier with their lives and had more physical complaints. They had lower self-esteem and they were higher depressed than age-matched gender population. And another scientist called as in 19 that the consequences of the deformity, especially immature children with progressive curves, could suffer from severe physical symptoms like back pain, diminished back is at this level, the pre-pubertal level. Already there are the dysregulations of the hormones. The child is very depressed. The child gets the mood swings. But on top of that, if the child is having an scoliosis, idiopathic scoliosis, what we call as that postural scoliosis or physiological deviation, or we can call it as biomechanical deviation, which is not the pathological condition, which can be detected earlier. So in that scenario, in that case, the child is more depressed and the child is feeling lower or less self-esteem. So even without severe progression, when the curves are usually not life-threatening and the braces or surgical treatment is used, the deformity may interfere with daily life and might have significant effects on health-related quality of life. When the curve magnitude progresses, when the girl's skeletal maturity is stopped and the curve is stopped, the curve does not progress, but there is no conservative treatment. There is no evidence proved that there can be a conservative treatment which can treat the scoliotic curve greater than 30 degrees. So the child has to go for a bracing or the child has to go for a surgical intervention. Again, the bracing is a burden for a child or especially for a female. And if the child goes for a surgical intervention, which again has got very pros and cons regarding the surgery, which again really had the impact on their health related quality of life. So these were the psychological and cosmetic concerns of idiopathic scoliosis. Now you'll be asking like how to recognize when we have our child. So if suppose, for example, if a layman mother or a layman father or a teacher, the one who has got no knowledge about the idiopathic scoliosis, how can we recognize at the early stage to give the proper conservative management or to improve the health related quality of a child? So the first part is home screening. We can go for a home screening. Second thing is we can go for school-based screening, and school-based screening, then further we can go for the evaluation methods and we can select the best protocol for the child. Then we go for phase 1. Cases for the scoliosis of a mild pain of its back, which can be any normal pain. The child cannot say that he or she has got a back pain. As again, I would like to share my experience. When I was doing my study, PhD study, the most of the participants, when I went to the schools, most of the participants told me, ma'am, we get back pain when we carry our heavy backpacks or when we go for prolonged sitting on a desk, a school desk, or when we do our homework, we just stoop forwards, or when we sit on a desk also, even though when we have a food on a dining table, we get a pain. But parents, like they just ignore it, and maybe they don't have any knowledge about it, what exactly it is. When we screened those children, and to my surprise, those children were detected as idiopathic scoliosis. The second phase can be a spinal curvature, where the curvature can be seen. If you see the picture there, the curvature can be seen, and there is an asymmetrical loading. The hip height will be one side, and the other side, the hip lowering will be there. The shoulder goes one side up and the one side down. That is the second phase of the idiopathic scoliosis. And whereas the third phase, there is a spinal deformity, and we could see the torso deformity in a child. So these are certain three phases where we have looking. Now coming to the home screening, as I said, that first phase can be the home screening, and where we have to educate the parents, and this already I have done. During my studies, I was educating parents. I was taking a PPT presentation for my participants' parents, and showing them how can a layman screen her child, or a mother can screen her child to detect the idiopathic scoliosis. This was a simple slide, what I show them, like parents can perform screening without the comfort of their own homes, like with the comfort when a girl is comfortable with the mother, so she can undress herself, where the mother can screen her for any deformity if she is having any. So in first thing, if you see the picture, the standing and facing you is in that it is one shoulder higher than other. We have to educate them whether the one shoulder is higher than the other, whether the arm is farther. If you just see that if the one arm is farther and the other one is closer, are the hips at level. These are certain points which can be which parents can be educated on screening of scoliosis. And the second thing is we ask the child to turn backwards, and we have to ask the child to bend towards you, that child is facing you, and we can see one side of the rib cage is higher than the other, and if there is a lower back uneven or the hips unequal or unlevel. The third one is standing and facing away from you. Is one shoulder higher than the other, or do the hips look uneven? And fourth one is bending away from you. The second one was bending towards you, and the fourth one is bending away from you. And again, we have to see that whether the rib cage is higher than the other. And the last one is turned to the side as the back looks overly rounded. So these are some points which can parent can be educated on this in order to go for a home screening. Coming to the screening, where we go for the team-based screening, the Scoliosis Research Society and the American Academy of Orthopedic Surgeons, Pediatric Orthopedic Society of North America, and American Academy of Pediatrics have released an information statement that support scoliosis screening as a tool to identify patients with scoliosis at early stages and recommend performance of scoliosis screening twice in girls in the age group of 10 to 12 years and in boys at the age group of 13 to 14 years. As per the WHO guidelines, if we see that a girl attains the maturity in the age group of 10 to 12 years, whereas the boy attains the maturity at the level of 13 to 14 years. So that is why this age criteria is given by WHO and by the Scoliosis Research Society, and they have recommended that this age group is the correct age group to screen the child for early detection of idiopathic scoliosis. And this is a conceptual framework given by the Scoliosis Research Society, and they have just given as the first thing is the clinical effectiveness, and it is very important health problem. If we see that idiopathic scoliosis, it is a very important health problem, and it has got an adequate health service provision is possible. And we don't know what is the prevalence rate, what is the referral rate. When the child gets the mild curvature, moderate curvature, the magnitude of the curve is high, the parents comes to know, and they just come and brings the child to the orthopedic department, the orthopedician, the spine surgeon goes for a surgeon. Physical therapist, we all, if we just take the initiation, the treatment for the scoliosis, we can stop the progression of the idiopathic scoliosis in order to improve the quality of life in a child. And we have to see, second thing is the technical efficacy. What are the valid and the reliable tools which we can use to assess the scoliosis. And the third one is cost effectiveness. We have to see the cost effectiveness. It should not be a burden for the clinician or a therapist or the researcher, whoever is taking screening, or it should not be a burden for a parent as well. And the treatment effectiveness, we have to see scientifically based treatment programs has to be taken care for the child based on the type of the curvature and the magnitude of the curvature. This is the framework given by the Scoliosis Research Society in order to evaluate the idiopathic scoliosis. Now coming to the clinical evaluation, when we talk about the valid and reliable tools, and we talk about the cost effectiveness, so what are the tools available with us which can be helpful in order to determine the idiopathic scoliosis? Labila et al. In 2013 said that Scoliosis Research Society considers that Adams forward bending test as a reliable and valid measure for trunk asymmetry. So as we all know that Adams forward bending test, we ask the child to bend forward and we see the rib prominence at the back of the rib. So we can just, this is the Adams forward bending test, but this alone is not the valid tool to assess the idiopathic scoliosis. Another scientist came, that is Bonangamba et al. And Silho et al. In 2013 and 2010, they said that scoliometer, if you see the picture at the left hand side of my side, there's a scoliometer where we are detecting, this is my patient, I'm just monitoring her and I'm just evaluating her and doing the clinical examination to assess her back to find out the idiopathic scoliosis. So this tool, baseline, it is a scoliometer, it has got a valid, it's a valid and reliable tool, and it has got a correlation, good correlation with the radiological analysis, which have been proven as significant results with the radiological evaluations. So next one is people are joining now, so I just have to admit them, sorry. So Gaudia et al. In 2015, it shows that scolioscreen, if we all know that down there is a picture, it's me, I'm holding a phone over there. So it is an iPhone. So there is a scolioscreen measurement application or iPhone application, or it is called as scolioscreen or scolio watch application, which can be downloaded in the phone, and that has got equivalent reliability with the scoliometer. And with the help of this app also, we can assess or we can do the clinical evaluation of the idiopathic scoliosis. These are two certain tools which have been very valid and reliable tool to assess scoliosis. So here is a small data I would like to present. This was my study. I conducted this study for 100 participants, where 100 prepubertal girls are in the age group of 6 to 13 years. I took the children from 1st standard to 8th standard, that is as per Indian standard protocol. They were in the age group of 6 to 13 years. It was based on 5 schools. I went to 5 schools where I screened 100 girls. Each school, like 20 girls were randomly selected for the screening, and 3 of them had a pain. When we just assessed them, I assessed them, also saying that they complained of a pain while bending forward and while carrying back. In this data, we found that 6%, that is 6 out of 100 prepubertal girls were positive, that is at higher risk of idiopathic scoliosis. We found 5 degree of ATR, that is axial trunk rotation with the help of scoliometer, and 7 degree of axial trunk rotation with the help of scoliometer and the scolio watch. Then same patients were referred for our university in the orthopedic department, where an orthopedician evaluated again, and we sent them for the X-ray measurement, and X-ray measurement, to our surprise, it was Cobb angle shows less than 25 degree, where the parents and the teachers were unaware of all these things, and all those curves, all 6 patients had the curve at the right thoracic level. So in these cases, when we started them the protocol, we gave them a protocol for around 9 months. Conservative treatment was given them for 9 months, and there was a significant results. We found that there was a significant results. The ATR was diminished, and the students' pain level was not much reduced. That did not show us the significant results, maybe because of the adherence of the exercises. They were not much adherent to those exercises, but from the baseline to the post intervention, the cob angle what we assess by radiograph and axial trunk rotation with the help of scoliometer and with the help of scolio gauge, that showed the significant results. Now coming to the ethical considerations, like when we talk about ethics, like it is when we are a researcher, we are a clinician, we always have to consider some ethical considerations has to be taken care. So when the patient comes to us in our clinic, we have to take care of the ethical considerations, or if we are a researcher, we have to take care of the ethical considerations in participants. So suppose we are in my study, like I had in participants, it was a clinical study, and it was a research, PhD research, and I had certain ethical considerations to it. So I have just given some slides. What are the ethical considerations can be taken when the patient comes to our clinic or department, or we are a researcher? So first thing is informed consent. Informed consent is very important. That is the autonomy and the self-respect of the participant who is willing or unwilling to take part in the study or unwilling to take part in the treatment protocol as well. So informed consent, it is nothing but the willingness and agreement to undergo a medical intervention. That is the informed consent we have to take from the parents, or we can take from, in case of child, I'm talking about the idiopathic child, informed consent has to be taken from the parents, and informed assent. Assent is from the child. A child also has got the autonomy to give the consent whether he or she is willing to take part in our study, or whether he or she is willing to allow us to do the clinical examination. For example, if the patient comes to our department, physical therapy department, with some back pain, so it is our duty as a physical therapist, we have to take the informed consent from the patient or from the child, assent from the child, in order to make sure that the child is comfortable for evaluating his or her back. Now we'll come to know what is informed consent. Informed consent, it has got no legal definition. Under section 13 of the Indian contract law, it is defined as two or more persons are said to be consent if they agree upon the same thing in the same sense. That is the definition given by the section 13 of the Indian contract law. Coming, how is consent viewed? How it can be viewed? It is a permission, principle of respect for autonomy, and it's a contract between the service provider and the patient. What to inform? What all things we have to inform? So when we talk about the idiopathic scoliosis, so there are certain psychological concerns, cosmetic concerns. The child is depressed, child is feeling low esteem. Parents are concerned because it's a girl, she is concerned, mother is concerned, father is concerned. So that is very important. The informed consent has to be taken from the parents to make ourselves safe and to make them comfortable. So what has to be there in the informed consent? It has to be in a very simple language which a child understands and which a parent understands. And if the parent is uneducated, so that can be given in the local vernacular language, which is very important for them to understand what is happening with that child. So when I did my study, I took a PPT presentation for the parents. I educated them what exactly I was doing, as I have conducted my study in Dakshina Kannada, but I am not from Dakshin Kannada. I am a North Indian, but still, like, I was having a difficulty in the communication in my study. Then I had a social scientist who helped me in communicating with the parents. She was a translator, and I was just communicating with the parents in order to make them confident, because the psychological concern is not only with the child here, the psychological concern is with the parent as well. When the parent comes to their daughter, the one who is hardly 10 years, 12 years, has got some curve, so they also will be depressed. So in order to make them confident, we have to explain them what exactly we are going to do with your child. So we have to explain them about the condition in a layman terminology. What is the procedure we are going to do? What will be the prognosis? What will be the benefits and the significant risk? What are the additional procedures that can be followed if the conservative treatment is not working out? What are the other options? What is the cost? What is the duration of the admission if the patient is getting admitted in the hospital for conservative management or the post-management or follow-up? So these are very important factors which we have to look in order for the psychological concern of a parent as well as a child. Now coming to the treatment options. Treatment for scoliosis is determined by the type of scoliosis, the current magnitude of the curvature, and the remaining growth trajectory of the child. So exercises, which includes Leon approach, the Scroth approach, scientific exercise approach to scoliosis, the side shift approach, and the functional therapy, individual therapy approach of scoliosis, etc. These are the scientifically proven exercise protocol which has got very significant results in the early detection when we early detect the scoliosis and we give them this protocol, and these are the very beneficial and very highly significant exercises which can be administered to the idiopathic scoliotic child. When we talk about the curve that is 25 degree to 40 degree, the bracing is advisable. But bracing, again, if we talk, when I already discussed, the many studies have been conducted how the bracing has got an impact on a child's mental health. And surgery is recommended for greater than 45 degree, which again has got an so many disadvantages, and which the child is getting very much depressed and lower esteemed. So the aim of this presentation is like we have to go for an early screening in order to detect the child for idiopathic scoliosis and to give the early detection and early treatment in order to improve the health related quality of life in a child. Now here I'm talking only about one protocol which I have found very significant, that is the SEAS protocol, scientific exercise approach to scoliosis, which is given by a scientist called as Romano et al. He is the founder of this SEAS protocol, and he has given the SOSOT guidelines, that is the by 2015. SEAS, Michael Romano said that Cs stand alone in low medium degree curves during growth and reduce the risk of brace. So Cs is the protocol which stands alone to reduce the risk of bracing, and it has gotten significant results. And it can be performed as close as possible to physiological positions, allows to stop curve evolution, to recover a position of the misalignment, and to bring the patient the end of the bone maturation with good hope of avoiding worsening in adulthood. West et al. In 2005 and Sosot and Sekros defined that Cs is a three-dimensional self-correction exercise. If we talk about the scoliosis, it is also called as three-dimensional deformity. So Cs is a protocol which is also called as three-dimensional self-correction protocol or auto-correction protocol. Here in this Cs protocol, we are not using any external aids to train or to rehabilitate an idiopathic scoliotic child. Cs protocol is training the automatic response to the achievement of the more correct questions. It gives the inhibition of the automatic reflexes where the child corrects his or her trunk asymmetry. Negrini et al. In 2019 said that effectiveness of Cs in current of 11 to 20 degree at the start of puberty below 25 degree of scoliotic curve. So Negrini in 2019, it's a recently done last year's study. He has done a tremendous work on this. He has taken 3 pubertal girls with a degree of 11 to 20 degree. That is, cob angle was below 25 degree, and 11 to 20 degree was axial trunk rotation detected by scoliometer. And the Cs protocol was given to those children, and he found a very significant results. And and he prevented the risk factor for the scoliotic patients to go for the bracing and to go for the surgical intervention or to progression of the curve. Cs, which I already said, it's a dimensional self-corrected exercises. It trains the neuromotor function and stimulates by automatic correct reflex response as subconscious self-corrected activities during daily life. So it is the activities where we train a child like he or she has to self correct their posture. So when we correct their posture, so it comes to their subconscious mind. It has got some cognitive effect as well. So it comes to their mind. So they adapt in their mind. So it, whenever they go for any daily activity, they try to correct their posture. So in order to, so they try to correct their physiological trunk, and which has got the biomechanical consideration, which is not the pathological entity. It has got no pathological entity. So CES has been a very good protocol regarding this. So when we include organization of patterns in the C's, we include the organization of patterns of trunk muscle recruitment. Here trunk muscles plays a very important role, and neural structures serving axial and arm muscle control, and relevance of cognitive system in the building of body schema and mapping of spatial coordinates. So these are some factors which are included in the C's protocol. It improves the main spine function stability, and the exercise aims to improve the eventual impairment that the initial evaluation may highlight, that strengthen muscular retraction, it has got a motor coordination, etc. It is based on a single word called as control, where we ask the 4 questions to the patients, that is relax, symmetry, challenge, and return. When we just put the patient in a relaxed position, either it can be sitting position or it can be standing position. So we always ask the patient to sit or stand relaxed. And postural mirror can be used for the patient to see the curve, front and back. When the patient is in the sitting position, in a relaxed position or standing position, the curve is automatically seen by the patient. The curve can be seen by the child. Then second question is, we ask the child to go for the symmetry. We train them how to go for the physiological correction of the spine. So when they correct their spine, the symmetry changes. The child can see the symmetry of the spine. The third one is challenge. It is a challenge when we ask the child whether he or she is able to hold the position. When the child says yes, it is very difficult for me to hold. So this is a challenging opportunity and a challenging question for us, that our protocol is really working well. It has to be difficult for the child to hold the position. Then slowly we ask the child come back to the return position. When the child comes back to the return position, again the child goes for the asymmetry of the spine. So here the child can see that what was the initial stage when the child was in relaxed position, what was the curve magnitude of a spine. When we ask the symmetry, change the symmetry, and just challenging questions in order to correct their physiological trunk or the biomechanical considerations with the help of the trunk muscles, they can see the correct posture. And when we ask them to return it back, they again go for the asymmetry. So this is sort of cognitive behavior, what they develop in their mind set. So whenever they are going for any daily activity, they try to adopt the same posture. So this is the protocol. It's the copyright. Actually, these are not my patients. It's the copyright from Negrini. He was treating patients with this. If you see the first picture, we have asked the participant or a patient to sit relaxed. If the patient is relaxed, then we can see the curve is there, physiological curve is there. Next thing is we have to, the challenging question is we have to train the participant to go for the symmetry. So we have to change the symmetry of the trunk, and you can see the second picture how the trunk is being symmetrically changed. And slowly we have to ask the patient to stand from sitting position to standing position by maintaining this position. And second thing is from position, same position, then coming back and again sitting back in a relaxed position. So I don't have time, that much time is not here to explain each and every protocol. So you all can go through the C's protocol, what are the phases, how we have to train the participant to give a C's protocol. This is my patient, these are my patients. So first thing is, before giving the SEAS protocol to my patients, which I already showed in the previous data, like I found 6 participants in my study. That was my pilot study for my PhD. It was 100 participants. Among 100 participants, we found 6 participants as a positive, that is scoliotic posture, and they had around 3 participants had a 5 degree of curve, and sorry, 4 participants had 5 degree of curve, and 2 participants had 7 degree of curve. And finally, we gave them the SEAS protocol for 9 months to see the efficacy of the SEAS protocol. And before that, I educated the parents, because I already said, before educating a child, it is very important to educate a mother. I educated the mother. I took the classes. This is our orthopedic department, OPD department, where my guide and the mentor is orthopedic surgeon. I'm very highly thankful to my guide and the mentor, the one who has trained me and who has given me an immense knowledge about idiopathic scoliosis. I'm highly thankful to him. And he has this is the seminar room where I was given the participants the explanation about the protocol, what exactly we are going to do with the child. So then we have just taken the protocol. She's a child. She was around 10 years of old, and she had a 7 degree of curve. And when we gave her the protocol for 9 months, SEAS protocol. And finally, when we again for the radiograph, every 3 months I was taking the evaluation protocol, whether there is any progression. At the 9th month, when we saw there was a tremendous effects of SEAS, we could see that if SEAS really worked very well, and the curve was reduced to 5 degree, and she had no pain. It was a mild pain when we compared with the pain. The numeric pain scale was taken. It was not significant that much, but still she was comfortable while sitting and writing her homework. This is the data what we have seen, that in the mean changes of axial trunk rotation and the pain baseline and the post intervention, which again I said that it was insignificant results, but in the pain scale we could not find much results. But when I carried out the same study for the larger population, I did the study for 600 children, where I found 26 as positive cases, and those participants, we found some tremendous effect on the pain as well. So if you see the pre and post effect of those participants, picture A, we have seen the surface markings is very important. So the surface marking, this is the marking where we found the curve. You can see that the scapula level, the shoulder level, and the post effect you can see with the B picture. The same child after the SEAS protocol, and the C picture is the second child before SEAS protocol, and the D picture is the same child after D protocol. So, but we in this study we did other tests also, which I have not mentioned in the slides, which is called as flexibility push test. So as already mentioned, that some scientists have said that if we go for the Adam forward bending test, and then we go for a radiograph, and we can find that whether it's a structural or unstructured. But when we go for a screening, that time the radiography is not available, and radiography is not much in the support for the prepubertal age also, because many studies have shown that if the prepubertal girls go for repeated radiographical changes, and they can develop the breast cancer. So in order to avoid all these things, we have a test called as flexibility or push prone test, where we ask the child to lie down in a prone position, and we push the spine, that is the clinician pushes the spine that medially and anteriorly, and we can see the rotation prominences. When the rotation prominences, when we leave the hand, so the rotation prominences come back. So that means that it is a flexible curve, which can be treated with the help of conservative management. And another test where the patients complained of back pain in our previous study, the second part when I took, like it was for 600 participants, we went for an Bering-Sorensen test. In that, I was assessing them for the trunk tensor muscles to assess their endurance in order to assess their back pain. So if they have then less endurance was noted, so those patients were prone to get the back pain with compared to the other participants whose trunk muscles were strong enough. So a Bering-Sorensen test, it is a simple test where we ask the patient or the child to lie down in a prone position at the couch level. The edge iliac crest is that at the couch edge level, and we have to strap the knees and the pelvis in order to support the child, and we ask the child to cross the arms around the chest and lift the shoulder, extend the shoulder. When the child extends the shoulder, the stop clock has to be maintained. If the child holds it for 120 seconds, so that means the trunk extensor endurance is good. But if the child drops it below 176 seconds, that means the trunk extensor muscles have got less endurance. In that case, we were giving them some back strengthening exercises in order to train or in order to strengthen their back muscles. So these are certain studies conducted on SEAS protocol. These are some evident proved exercises which they have compared the SEAS protocol with the bracing, that is with bracing and without bracing. Again, the SEAS protocol have shown a very significant results. And this is just to show you all these. I don't have that much time to explain each and everything about this study. So these are all supporting studies to the SEAS protocol. Coming to the summary of this presentation, progression of the deformity depends on the skeletal maturity. So when the child is on the skeletal maturity, prepubertal maturity, when the perfect protocol is given at the prepubertal level, the child can, progression can be stopped, and the health-related quality of life can be improved in the child. Psychological and cosmetic concerns can be taken care of for a child. The inclination of 7 degrees or greater is more acceptable in early detection of axial trunk rotation before the skeletal maturity of the spine. When we go for a baseline, that is scoliometer, or we can go for scolio gauge, if we find that 7 degree or 5 degree is axial trunk rotation, which is acceptable before the skeletal maturity, those children are at the high risk level. So we have to start with the protocol of our conservative management. It was shown that there may be flexible causes such as muscle imbalance. Showing right thoracic curve was due to the concave side muscle weakness. It is proven that many studies have proven that there are muscle weakness also, which I already discussed. In order to determine the muscle weakness, trunk extensor muscle weakness or the endurance, we have gone for the Behring-Sorensen test, and later on, based on the data what we collected, and we have given them the strengthening protocol and strengthening exercises. Those, for example, those patients who were not detected with idiopathic scoliosis, but their endurance was less, trunk extensor muscles endurance was less, but still they were given a strengthening protocol, and they were asked to do it at home, or the teachers were trained for the same protocol. And in SEAS, it is necessary to use the intrinsic muscles of the spine as much as possible to propose a functional conceptual shift and best functional stimulation of the independent contraction of muscles, train for the search of the best alignment of the spine. So I would like to conclude with this, saying that skeletal maturity of a child is very important, and during that case, if we detect the scoliosis based on screening, whether it's an scoliosis screening on school based, or it's an departmental based, or it's an camp wise. So this is the betterment, because it's a social health problem throughout the world, not only in the India. And to my surprise, I can say that till in India, there are no scoliosis screening going on. So I'm very proud to say that our Yenapoya University is going to have a screening center soon. So we are going to have a screening center for the scoliosis, where we'll be screening every year. We'll be screening the school children for scoliosis, and we'll be giving them the best protocol as per their curve magnitude. And if you go for the scoliosis screening, if the patient comes to your department or your clinic, if you are assessing the patient with the scoliometer, and if the curve is axial trunk rotation is 7 degree, that has to be taken in the high risk factor, and the patient has to go for an X-ray radiography to assess the cob angle, or straight away if the radiography, again the permission is needed for the radiography for the parent as well. Because in my study I faced a problem, like many of the parents did not give me the consent from the radiography. Yes, they gave me the consent for the axial trunk rotation measurement. I was taking them in front of the parents, but some of the parents did not give me the consent for the radiography, so I had to continue with the axial. So there is validity and reliability of the scoliometer, so I was not much worrying about that. So to give the entrance, there is no external aids we are using. It's all the intrinsic muscles based on the self correction, where a child can correct herself or himself on basis on the daily activities. So this protocol can be given weekly basis, daily basis, but to my participants I had given on weekly basis for 20 minutes. I used to train them, and every 3 months I used to take the successive clinical evaluation for the participants. So after successive evaluation of the participants, then we used to give them the protocol. But every time that I used to maintain the adherence of the exercise protocol, which is very important. So adherence has to be maintained for the significant results. Thank you so much. Thanks a lot. And I thank Dr. Mohammed Jalil for giving me such a wonderful opportunity. And thank you all for your valuable time. And stay safe, stay happy, and stay healthy. If you have any questions, I'm ready to answer you all. Thank you so much.
Thank you, Dr. Mudasir, for your wonderful talk. Very detailed and very extensive and very useful. So let's open the platform for any questions. So I'm going to unmute all. So
sorry to interrupt you. Sorry to interrupt you, Mohammed Jalil. I'm not able to hear you properly. The voice is breaking.
Sorry, I said I have just unmute all the candidates. So they can ask questions one by one. And if somebody is not able to access via the voice, they can also send a chat on the group chat, and I'll be happy to ask the question on your behalf to Jayanti. And I would request all the attendees to mute their mics if you're not asking questions, please.
പിന്നെ ഏറ്റവും വലിയ ബാരിയർ എന്ന് പറഞ്ഞിട്ടുണ്ടെങ്കിൽ
exercise
will cause injury, pain അല്ലെങ്കിൽ discomfort. അല്ലെങ്കിൽ അവരുടെ it will exacerbate their physical condition. അതാണ് അവർക്കുള്ള കാര്യം. ഓക്കെ, അപ്പോ നമ്മൾ എന്ത് കൊടുക്കണം? Special consideration should be provided for promoting this elderly population to physical activity.
Sorry, is it somebody asking a question or a comment or?
Yes, Bebe.
Hello.
Hello, yes.
Hello.
Yes. Do you have any questions?
Yeah. Any questions, please?
Yes, you can ask your question directly to Mudasir. Or if you have problem with your voice, you can type your question in the chat and I can ask her for you. So I'm guessing, Mudasir, there are no questions from the audience. I think your
right,
presentation was so wide and so in depth that everything was very crystal clear.
Thank you so much. Thanks a lot.
So what I'm going to do is after we end this meeting today, I'm going to send an email of speakers' feedback to all the attendees, and I kindly request all the attendees to give your feedback online via the SurveyMonkey website, and then I will pass on your feedback to Dr. Mudasir. So it will also help us to plan further sessions more efficiently. So I thank Dr. Mudasir for her participation today, and I also thank all the attendees for giving the time and listening patiently, and we hope to see you in our next session soon. So thank you, everyone, and Dr. Mudasir, a big thank you to you.
Thank you so much. Thanks a lot. Thank you everyone for joining us. Thanks a lot.